and welcome to ESC Cardio Talk. I'm Roxana Moran, interventional cardiologist, professor of medicine, cardiology, population health science, and policy at the Icahn School of Medicine at Mount Sinai.
And I'm Dominic Angelillo, professor of medicine and interventional cardiologist at the University of Florida College of Medicine in Jacksonville.
Today we're discussing atrial fibrillation with ACS and PCI, walking a tightrope. It's the topic of our featured editorial in the European Heart Journal. This was a very interesting study. I think it was a sub-study of the Redual PCI study, looking at two different doses of dabigatran, 110 milligrams POBID or 150 milligrams POBID without aspirin on top of a P2Y12 inhibitor versus a triple therapy standard of care arm in patients with atrial fibrillation. This particular study that we looked at is an ACS sub-study. So Dominic, you want to share with us what we saw, and our view with the editorial is it is a tightrope, isn't it?
Absolutely, it is a tightrope. Let's just start off by saying just what the main trial showed, and we'll dig in a little bit into what our editorial explored based on this very nice analysis from the Redual trial. We know that the main Redual trial results published in New England Journal of Medicine demonstrated that the strategy of dual therapy with dabigatran, irrespective of dose, together with a P2Y12 inhibitor, mostly clopidogrel, was associated with a reduction in bleeding complications without any apparent trade-off in ischemic events. Here, the authors, they did a really nice job in looking to patients who presented with an acute coronary syndrome, and they also did a very nice analysis looking into patients treated with ticagrelor. Very, very limited data from that standpoint. And let's start off with the first question, the ACS. We know that these patients are at high risk for recurrent ischemic events. Patients also at high risk for bleeding. And what the study nicely showed in a rather sizable proportion of the patient population, that the effects of dabigatran, irrespective of dose, were very, very consistent in reducing the bleeding complications, as well as not showing any trade-off in ischemic events.
And that was a really important question, because in the acute coronary syndrome patients, because if you remember in the main Redual PCI, there was this possible, not that the P interaction was negative, but there was a question of increasing ischemic events, especially with that 110 milligram POBID dosing. And that was a big question, because in ACS, we're very reluctant and very much on top of making sure that these patients do well and get the ample dual antiplatelet therapies that they need. But in combination with dabigatran, it seemed like there might be a noise, but here in ACS, the effects were exactly consistent.
Absolutely, exactly consistent. That part could also be related to the size of the population that within this subgroup. I still believe that the fact that we have two doses that are available give treatment options. As you're aware, in our North American consensus document, we actually included some of this information, even though they were not fully published, but they were presented as an abstract at the time. So we had some insights also thanks to Chris Cannon, who's the lead PI of the overall program. And it gives us some wiggle room. So we may consider the 150 in those patients who you may deem at higher ischemic risk, and the 110 in those patients maybe at a higher bleeding risk. So we have the options.
No, and I think it's really important. But on the subject of ticagrelor, I have to tell you, I'm underimpressed. It's a very small number of patients, and I still don't believe that we have any kind of a safety or efficacy data to combine these potent agents with oral anticoagulants. Do you agree with that? And I think your consensus is in line with it.
So there were 11% of the overall redual population that were treated with ticagrelor. Now, to their credit, it is the largest sample that we do have available with the newer agents, because the only data we had available came from Pioneer, which was only 4 or 5%.
4 or 5%, yeah.
So, and even now with the Augustus trial presented today, similar numbers. So, I think the authors need to, deserve merit for allowing investigators to look into this. And yes, you are correct. Although there wasn't an interaction there, when you look at the absolute numbers, there was a higher rate, as we expect, of bleeding with the use of ticagrelor. So it all narrows down. What do we do, right?
I think for us, we wanted to congratulate the investigators for actually coming out and showing us these data, because that's really important. But also a caveat that it is a subgroup of patients, and we really don't have the clear answers on ACS patients. And I do believe that your North American consensus tells us that we still have to walk the tightrope of balancing ischemia and bleeding complications. And your consensus gives the physician the choice of choosing a less bleeding avoidance strategy versus going full force on a triple therapy if needed for a shorter duration of period of time. Do you want to expand on that a little?
Sure, absolutely. Well, our awareness and appreciation for bleeding actually comes from all your research for the past several decades, and bleeding is clearly a bad thing. And we hear a lot when these studies come out, even at this meeting today, everybody's focusing on that small numerical increase in ischemic events, but not missing out on the big picture of that 50% relative risk reduction in major bleeding complications, and not counting what is the impact on cost, hospitalization, the whole picture. So yes, I agree that we need to be very cautious in these patients. I think ticagrelor should be reserved really for the highest risk ischemic, high thrombotic risk patients, but only if they also have low bleeding risk. And this is what we mentioned. And absolutely no aspirin in these patients if you're combining with a NOAC. It's a very narrow indication, but this is what we mentioned. So, Roxana, you've been involved in the field for so many years. I love the slide that you've used in the past, avoid stacking on. Where do you think the future is going when it comes to bleeding reduction strategies, whether this is related to AFib plus PCI or not? I mean, you've pioneered this field.
Well, no, thank you so much. I think there's a lot of great data now, and I think we as interventionalists or even physicians are always very reluctant to get rid of the old cheap therapies, whether they're good or not. And we believe that stacking the therapies of antiplatelet, anti-thrombotic regimens on top of oral anticoagulants, this is just really pushing the envelope way too far. And I think instead we should be switching out and doing other things. And so the one trial that I'm obviously excited about, and even more excited after Augustus, when we saw a 90% reduction in bleeding complications with withdrawal of aspirin in the Augustus trial in a double-blind placebo-controlled fashion. We're doing the same in Twilight in PCI patients, not AFib, but PCI patients. So it is a randomized study where we will be using a double-blind placebo-controlled aspirin withdrawal at 3 months after dual antiplatelet therapy with aspirin ticagrelor, and keeping the patients on a ticagrelor monotherapy after complex PCI with or without ACS. So it's a very, very labor-intensive study that you've been involved in, and we're hoping to present this in October or September at TCT 2019. But for now, I think, we saw a couple of trials even at ACC presented with withdrawal of aspirin when you go to a single antiplatelet therapy. Why drop the P2Y12 inhibitor, drop the aspirin, and that's what they did. In those two trials, they showed a benefit in patients. These were mostly patients in Japan and Korea, and very, very low event rates, and a smaller patient population. But then again, kind of opening the sliver of hope that maybe we're moving in that direction. The other possibility for these types of patients, especially those at high bleeding risk, is for us to think about the seatbelt that we can put on, which could be aggressive lipid lowering with PCSK9 inhibitors. And that's my next project and that I'm working on. And I think these are the kinds of things that we can do as physicians to make sure that our patients are getting the best possible therapy. But for now, we walk the tightrope.
Absolutely.
That's all the time we have for today. Thank you for listening. Discover other podcasts in our library and check back regularly for another ESC Cardio Talk.